So let's come to INICET November 2025 recall, and here is the question number 1. So this is a male child who shows 46XY, and there is a deletion involving chromosome 15Q, and the typical point they have given is region is 15Q 11213 deletion. Okay, so this is a particular deletion that they have given you, and they ask you what is a syndrome. So guys, you have to remember this answer to this question is Prader-Willi syndrome, and let's understand why. So to understand this question, you have to understand that this is a disorder of imprinting. Okay, so what is imprinting? Remember, imprinting always means silencing, and silencing is a normal phenomena because this occurs normally before fertilization. Okay, so always remember, let us say this is pink, which is a maternal copy, and this is blue, which is a paternal copy. So this is maternal and paternal, so we all get a gene, one allele from the father, one allele from the mother. So we have two set of allele for a given gene. Okay, so now let us first look at, suppose there is maternal imprinting. Okay, so maternal imprinting. Okay, so child has no option but to express paternal genes, okay. Now that means, can I say, suppose if there is a maternal imprinting, this imprinting is there before fertilization itself. Okay, so child has to express only paternal alleles. Okay, now something happens in 75% of the case. Suppose there is deletion of the paternal allele, there is deletion of paternal alleles. Which alleles, which genes? So this allele is present on chromosome number 15q, where, how do you define the address of the gene? So for that you have to use the formula called as carbs. Okay, so what is carb? So C is chromosome, so whatever is the chromosome, let's say 15, then A is the arm, so let's say 15q. Okay, from the centromere we'll define the region, so we'll go up, we'll say 1 2 3 4, 1 2 3 4. So let's say region 1, so let's go to the region 1. In the region 1 there are light and dark bands, so we number the, in region 1 itself we will divide the bands, okay, so we'll say, okay, light and dark bands, so let's divide them further. Okay, so we'll divide them 1 2 3, okay, like that. So from band 1, okay, from band 1 to band 3, there are set of genes called as SNORPs. So what are SNORPs? These SNORP group of genes are basically, they are the genes which code for small nucleolar RNA. So these proteins get deleted. Okay, so from which, so I told you the carbs, C was chromosome, A was the arm, R was the region, and B is the band. So which bands are deleted? From 1 to 3. So region you have to define always, that is first region, and which band? Third. So from 1 to 3 bands are deleted, and they contain gene called as SNORP. So these genes are already imprinted in maternal, so mother can't express them. Paternals are deleted, so what will child do? So these genes will, because they are deleted in the paternal, so imprinted genes will start expressing themselves aberrantly, and that is what is called as disease. So whenever you see this phenomena here, that the maternal alleles get imprinted, paternal alleles get deleted. Okay, especially at the region 15q11 13, this is what is called as Prader-Willi syndrome. What is the syndrome called as? Prader-Willi syndrome. Remember, it can also occur by another mechanism. What is that other mechanism? Suppose due to some error in, replication, error in the, when the alleles were coming, there was some error, and child gets maternal disomy. So he gets both the copies from the mother, and both the copies were imprinted. So in both the copies, the SNORP genes were not expressing, they were not there. So child had no option but to start expressing the disease abnormally. So this is what is Prader-Willi syndrome. Can I say, when will you get Prader-Willi syndrome? When will you get Prader-Willi syndrome? First, you will get it when there is maternal imprinting. Okay, maternal imprinting and paternal deletion. So deletion where? at 15q 11 to 13. Okay, 15q 11 to 13. Or can I say you can also get this when you have maternal disomy. You can also get this when you have maternal disomy. So this is one thing which you should be very, very clear now. So remember, Prader-Willi basically occurs whenever you have maternal imprinting, paternal deletion, or maternal disomy. So that's Prader-Willi syndrome. And these patients usually presents with hyperphagia. So they're hungry all the time. And because of this, they get massive obesity, and they have small hands and feet. They have small gonads, hypogonadism, and obviously they are mentally retarded. They are mentally retarded. So they have mental retardation. So when you see this, that is Prader-Willi syndrome. So remember, Prader-Willi is always deletion of paternal alleles. Okay, so that is very important. And which genes are deleted? These genes are called SNOR. So these are small nucleolar RNA coding genes. Okay, let's go to the opposite part of the spectrum now. Suppose again we get one copy from the mother, one copy from the father, and this time the paternal alleles are imprinted. So paternal allele is imprinted. So which gene is imprinted? So when we say imprinted, whole chromosome can't be imprinted, isn't it? It has to be which gene. So this gene that is imprinted is at 15q. Look, remember, how do we define the address of the gene? 15q. And this is present on region 1 and in band 2. And this gene is UBE3A. So this is nothing but ubiquitin ligase. So this gene is imprinted. So we have imprinted here. Okay, so that means child has no option but to express the alleles from the maternal allele. So child is expressing UB3A from the maternal side. Now problem occurs when there is deletion of maternal allele. So if the maternal allele gets deleted, okay, then child will have no option, will have no UBE3A. So this will alter the synaptic functionings in the brain, and this will cause a syndrome called as Angelman syndrome. So also a clue to remember is, see, when mothers get deleted, they become angels. Okay, so when the mothers get deleted, they become angels. So deletion of maternal allele causes Angelman syndrome. And remember, so if we look at the Angelman syndrome, what is the classical feature? So what is the classical feature of angels? They are always smiling and they are always flying in the air. Okay, so can I say, so what is the typical feature of Angelman syndrome? They have inappropriate laughter. So they have inappropriate laughter. They are always happy. They have ataxia. Okay, so they are moving in the air. They have ataxia, and they are laughing so much that they can even fall down. So that is called seizures. This is just a way to remember. Okay, so they have inappropriate laughter, ataxia, and seizures, and that is why they are also called as happy puppets. They are also called as happy puppets. Okay, so they are also called as happy puppets. Remember, is there any other way in which Angelman syndrome can occur? So 75% of the time, the Angelman syndromes occur because of deletion. But in 20 to 25% of the time, they can occur because of, can I say, maternal disomy? Yes, so they can occur because of paternal disomy. Okay, so that means the person gets both the imprinted copies, so they will not have any working copy of UB3A, and they will have abnormal synaptic functionings, they will have ataxia, and again mental retardation. So remember, both Angelman syndrome and Prader-Willi are mentally retarded. So in the exam they can give you questions like these. Okay, so they can ask you, can you tell the gene in which there is maternal deletion, paternal disomy, paternal imprinting, and deletion of 15q12, that is ubiquitin ligase gene, that is UBE3A. Which syndrome are we talking about? So it's Angelman syndrome. Or they can change the question, paternal deletion, so maternal disomy, maternal so paternal imprinting. So once they say paternal imprinting, we know it is Angelman because mother will get deleted. I changed the question. Maternal imprinting. Maternal imprinting, maternal disomy. So who's deleted? Father is deleted. Paternal deletion. P for P, Prader-Willi syndrome. So that's Prader-Willi syndrome. Remember the gene here is 15q, but here it's a big band because they're group of genes. They're not one gene, they're group of genes. These genes are SNORP. So this is 15q11213. So that's very classical here, and that was the question here which was typically asked. So be very clear with imprinting. The rules are imprinting always occurs before fertilization, number one. Number two, imprinting, because errors of the imprinting are Angelman syndrome, Prader-Willi syndrome, Beckwith-Weidman syndrome. Number three, in imprinting, basically the errors of imprinting decide the expression of the gene depends upon the copy of the allele which is imprinted either in mother or father. Okay, so it depends upon where the imprinting has occurred. That will decide how the disease manifestation is going to change. So, right, guys, so that is about errors of imprinting, which you should be very, very clear. So now let's come to the question number 2 here. So what does question number 2 says? So this is a 5-year-old child presents with proteinuria, does not respond to steroid therapy. Renal biopsy shows segmental areas of sclerosis on histopathology. So very easy question, okay? Segmental areas of sclerosis they have already given. So this is segmental glomerulosclerosis, that is FSGS. So I hope you understand this, that even if they give you a histopathology image, you should be able to identify it. So whenever they give you a focal areas of sclerosis, that is a sclerosed areas sticking to the Bowman capsule. This is a very classical image that they are showing you of sclerosis. So this is very typical light microscopy of focal segmental glomerulosclerosis. So focal means when less than 50% of the glomeruli are involved. Segmental means that if you're talking about one glomerulus, part of the segment of the glomerulus is involved. So this is what is called focal segmental glomerulosclerosis. Usually the gene that is associated with it is ApoL1, which is typically seen in Africa because this protects them against trypanosomiasis. So that is classical here. Okay, now if you talk about the light microscopy, we should know what will you see on electron microscopy. So electron microscopy of FSGS will, it is a typical podocytopathy. So you will see damage to the podocytes, so or they can give you as foot process effacement. Okay, so that is very, very classical feature of your FSGS. There is foot process effacement, foot process damage, because it's a classical podocytopathy. And if you look at the immunofluorescence, you should remember that it is not an immune complex mediated disease. However, there is non-specific trapping of IgM. That is very classically seen in FSGS. So once we're clear with FSGS, what about the other options? Let's look at them one by one quickly. So they give you this image in which your all the capillaries, all the glomerular capillary basement membranes appear thickened. So uniformly, all the basement membranes are thickened. So this thickening of all the basement membranes, when you see, that is classically of membranous nephropathy. I hope you know the reason why, because in membranous nephropathy we have basement membrane which gets thickened. Okay, so there is thickening of the basement membrane, and this gives you spike and dome pattern. Okay, so this gives you spike pattern basically. Okay, so this is actually a spiky pattern which we have already discussed in the detail in videos, right? Now what is dome? So on electron microscopy, you will see that there are subepithelial deposits. There are deposits in the subepithelium, and this is what is dome. So dome is basically due to your immune complex, and spikes are because of proliferation of the basement membrane. So that is the reason for spike and dome pattern in membranous nephropathy. Of course, it's always an immune complex mediated disease, with most common antigen being phospholipid A2 receptor. So that's the most common antigen here. So therefore, you will see a very typical immunofluorescent pattern here, that will be dots everywhere. And this pattern is called as granular immunofluorescence. This is called as granular immunofluorescence. So this should be very, very clear. This is membranous nephropathy. This is one of the most common nephropathy to be associated with cancers. Know that. Coming to the next one, if they give you this image here, what is this? So what do you see? The capillaries in between are okay. Only the mesangium is getting thickened. Okay, so there is expansion of the mesangium which is in between the capillaries. So this is what is called mesangioproliferative glomerulonephritis, and this is the other name for IgA nephropathy. This is nothing but IgA nephropathy. If you look on the immunofluorescence also, it will be the granular immunofluorescence only, but it will be typically around the blood vessels, because mesangium is typically present around the blood vessels. So if you look at the deposit here, it will be granular immunofluorescence, typically around blood vessels, and you will see deposition of IgA IgG, and C3. So these are typically deposited here. So this is what is called as IgA nephropathy. Okay, so the IgA nephropathy is also called as mesangial-proliferative glomerulonephritis. So that is IgA nephropathy, which you should be very, very clear. Okay, so now once we come to this, so remember sclerosis is a unique feature of FSGS. Okay, whereas in IgA there is mesangial-proliferation, and in membranous there is just increased thickness of the basement membranes, and that gives you spike pattern. Dome is because of immune complexes which are deposited on the subepithelial sites. Okay, so that has to be super clear to everyone. Let's come to the next question here. So this question says that this is a 20-year-old athlete and he collapses during the practice session and he died due to cardiac arrest. His autopsy finding is given, and that's so classically here, which is given you. This is a typical banana shaped heart. So you can see there is a typical banana shaped heart because there is proliferation of the septa, thickening of the septa, and this increased thickness of the septa causes obstruction, outflow obstruction also. So that is an important cause of immediate death. Okay, so this is very typical HOCM. So hypertrophic obstructive cardiomyopathy. So what is the cause of hypertrophy here? So basically nearly 100% of HOCM are genetic disorders. So there is a defect in the sarcomere proteins. So they cannot. So what happens is, so when there is a defect in the sarcomere protein, these proteins are haphazardly arranged. These proteins are haphazardly arranged. So when they are arranged haphazardly, so this is also called as skelter-helter arrangement of the cardiac fibers. So when they are arranged very, very haphazardly, what happens in between them? There is interstitial, in this area, interstitial fibrosis starts. Interstitial fibrosis starts. So what happens? This septal wall appears very, very thickened. Okay, but because the cardiac fibers are not arranged in series, they are not arranged in parallel to each other. They are haphazardly arranged. They cannot contract together. I hope you remember the concept that in between every cardiac muscle fiber we have gap junctions, and calcium from one gap junction should quickly enter into the other second cardiac muscle fiber so that they all be together like a syncytium. But what happens in HOCM is, in HOCM what happens is the cardiac muscle fibers are haphazardly arranged. Because they are arranged haphazardly, they cannot generate the force together. So what happens? They appear haphazardly arranged, and in between area gets fibrosed. So it appears hypertrophic, but it is all waste. Okay, so what happens? Because of this, the heart cannot relax when the blood is coming. So heart cannot relax because it's anyhow thickened, it cannot relax. And plus, because there is an abnormal hypertrophy at the septa, it causes obstruction. So that is what is typical HOCM, which you should remember. And that's a typical gross that's given in that picture. And that picture that typically shows you a gross of a banana shaped heart, which is HOCM, right? So this is hypertrophic cardiomyopathy, which is typically shown in the picture, and that is the cause of death here. And what you should do, you should actually screen all the members of the family because 100% of them are usually genetic. So if I say that we have three major type of cardiomyopathy, which everybody should remember, we have dilated cardiomyopathy, we have HOCM, we have restricted. So in HOCM, we just saw that the heart muscle fibers were not able to relax properly. So it's basically a diastolic defect. Okay, restrictive also, something enters into the cardiac muscle fiber, so heart is not able to relax, so it's also a diastolic dysfunction. Whereas in dilated cardiomyopathy, heart is abnormally dilated, and because of abnormal dilatation it cannot beat properly, so it is a systolic dysfunction. Okay, so it's a systolic dysfunction. Okay, so remember, in dilated cardiomyopathy is a very common cardiomyopathy which usually occurs in the peripartum, post myocarditis, post any toxin. Most common cardiomyopathy after in a hemosidrosis patient is also dilated cardiomyopathy. After any toxin like cobalt, also dilated cardiomyopathy is very common. But genetic causes are also there. So again, dilated cardiomyopathy can be either autosomal dominant, or it can be autosomal, or it can be X-linked, or it can be mitochondrial. So most of the time it is autosomal dominant. And when we talk about autosomal dominant type of dilated cardiomyopathy, the most common defect is in the gene called as titin, which is the largest gene, TTN gene, which codes for a largest protein called titin. And whenever we have titin mutation, so you will see a typical nucleus which you can appreciate in the cells. These cells are called ninja star nucleus. That nucleus is called ninja star nucleus. So if you look at the ninja star nucleus in at least more than 5% of the cardiac myocytes, that means this patient usually has titin mutation. So that's a clue that if you have ninja star, okay, so like a haphazardly placed nucleus in more than 5% of the cardiac myocyte, you can have titin mutation. Otherwise, it can also be X-linked, which is usually seen in patients of Duchenne's muscular dystrophy, or it can be mitochondrial defects also. So again, dilated cardiomyopathy can show you various inheritance patterns. What about HOCM? So when we talk about HOCM, it's usually autosomal dominant, and the most common gene defect is in the I told you sarcomere protein. So it's myosin binding protein C or myosin binding heavy chain. So these are basically sarcomere proteins which are defective here, which is myosin binding protein C or myosin heavy chain. So they are the ones which basically causes your HOCM. When we talk about restrictive cardiomyopathy, there's something which infiltrates in the heart, and that is why the heart is not able to relax. That's restrictive cardiomyopathy. So once we are very, very clear with this type of cardiomyopathies, let's look at some of the grosses that they can give you in exam. So if they give you a heart which is all the four chambers are dilated, in fact you can even see a mural thrombi mural thrombi. So this is a very typical image of dilated cardiomyopathy. Whereas when you look at the cardiac muscle fiber in which we show banana shaped heart, this is very typical of HOCM. And look at the cardiac muscle fibers here. Can you see all of them are haphazardly arranged? Some are here, some are there, haphazardly arranged. That's so typical of HOCM. Okay, so please remember, somebody can ask you what is the microscopic finding of dilated cardiomyopathy. So grossly, all the four chambers are dilated, and there is and there can be even a mural thrombus. Okay, otherwise you can see hypertrophied cardiac muscle fibers, but they are arranged in proper order. In between that, there is interstitial fibrosis. So only two findings here: hypertrophied heart fibers with interstitial fibrosis. You can see here. Whereas in cases of HOCM, what will you see? You will see myocytes are disarrayed, so they are haphazardly arranged cardiac myofibers. They are hypertrophied, that's second, and third, interstitial fibrosis. So the classical catch point here is disarray, haphazardly arranged cardiac muscle fibers. So that's one point which everybody should be super duper clear with, right? Okay. Now once we are clear with this, let's go to the next question. So typical question they gave you is mother is heterozygous. Okay, mother is heterozygous, and she has some autosomal recessive or some mitochondrial disease. Which systems are typically involved in mitochondrial disorders? So remember, mitochondrial disorders, the organs which are typically affected are those which are helpful in oxidative phosphorylation. And I always tell my students to remember a triad. Three organ systems are typically affected: CNS, eyes, and muscles. So these three are definitely affected: CNS, eyes, and muscles. So if you can remember this also, look at this. I will give you an example like MRF. So you can see myoclonic epilepsy and ragged fibers. Ragged fibers. ME is always myoclonic epilepsy, and here we have red rag fibers. So these are very typical mitochondrial defect. Look at this next. NARP. Majority of them are acronyms: nystagmus, ataxia, and retinitis pigmentosa. So eye and brain. So so that means most of the muscles are typically involved. It can be cardiac muscle, it can be skeletal muscles. Muscles are typically involved. So basically, CNS is involved, eyes are involved, and muscles are involved. So muscle, they can give you any combination of these. Immunes are usually not involved, and again new nerves are not involved. Okay, so what does Robbins say? So at the snapshot from Robbins, it typically shows you involvement of CNS, muscles, which can be skeletal and cardiac muscle, eyes, and liver and kidneys can also be commonly affected, because liver and kidney are again two organs where you have a lot of mitochondria. That is why there is a tumor called as oncocytoma, a tumor which has rich in mitochondria. This is very common in kidney. Okay, so that's another point that you have to be super duper clear with. Remember this, so that is typical of mitochondrial, and I hope the pedigree of mitochondrial should everybody be knowing that. So when this is basically the mitochondria, the ova always contains, the zygote contains the mitochondria from the mother. So when mother has the disease, all the children get the disease. When father has the disease, no child gets a disease. Again, when mother has the disease, all children are affected. So that's very, very typical of mitochondrial pedigree that they can give you. When father is affected, nobody is affected. That's your mitochondrial inheritance, which you should be super duper clear with. Okay, let's come to the stains here, which was very classical question here. Again, if you've understood the stains, and there's a very beautiful video of stains in the app also. So in the new videos, the stains basically, you have to identify the stains very nicely because that's a question that they typically ask you. So whenever they talk about stains, you have to be super clear with what are you dealing with. Okay, so always remember that we have to be very, very clear with the stains. Okay, so whenever we talk about Verhoff von Giesen, Verhoff von Giesen is also called as elastic von Giesen. So this is a stain for elastic fibers, and elastic fibers give you black colors. Okay, so elastic fibers give you black colors. Okay, so that's a black color of elastic fibers which you will see. So this is Verhoff von Giesen or von Giesen elastic, or they can also give you elastic von Giesen. So same thing, the only thing is the elastic fibers will always take the black color. Look at the second one, calcium stains. So whenever I'm talking about stains for the calcium, so we have two stains. One is the most commonly used stain. So most commonly used stain is von Cosa. What does von Cosa do? Von Cosa basically binds with the compounds of the calcium, doesn't bind with the calcium directly, and it gives the black color. Which is the most specific stain? So specific stain is always alizarin red, because it directly goes and binds with the calcium and it gives you red color. The name itself is alizarin red, so it will give you the red color. So most common is von Cosen, but it does not bind with calcium directly. It binds with the compounds of the calcium. Specifically, who binds with the calcium directly? It is always alizarin red. Okay, so these are calcium stains. Okay, coming to the next, Giemsa. So whenever we talk about Giemsa, Giemsa is a stain which is a metachromatic stain. Metachromatic stain means that whatever color you're going to put, the color that is going to come out is different from whatever color you're going to put. Okay, so that's called metachromatic. Suppose if you're putting, let's say, crystal violet. Okay, so if you're putting crystal violet is also a metachromatic stain. So when you put it on amyloid, the stain that will come out is pink. So you're putting a violet color, but the color that is coming out is pink. That this kind of stains are called metachromatic stain. So Giemsa is a metachromatic stain. Okay, so what does it do? So Giemsa is a blue color dye, but when you put it on mast cells, when you put it on mast cells come out to be purple in color. Mast cells become purple in color. So you put blue stain, but color that comes out is purple. So that's metachromatic. So Giemsa stains mast cell purple in color. So that's typical mast cell. You can see the coarse granules which are covering the cell. That's typical mast cells. Okay. So there are two stains for mast cells that you have to remember. One, Giemsa. Second, toluidine blue. Remember these two. Okay. Apart from that, look at these. This second important property of Giemsa is to identify these. What are these? These are Helicobacter pylori. So H. pylori is a gram-negative bacteria, and it is beautifully identified by Giemsa stain. Okay, remember, it does not infiltrate into the epithelium. It just stays in the mucus. So remember that point always. So that is H. pylori. You have to remember mast cells. And for hematology and for parasites, we can always use Giemsa stains. Okay, so that's your Giemsa, which you should be clear. Last, which everybody knows, this is Pearl's Prussian blue stain. So look at the color, it is Prussian blue stain. That's for hemosiderin. It always identifies iron in Fe3 plus form. And what is the cause of this color formation? It is always ferric ferrocyanide. That's the compound which gives this blue color. So always remember that is ferric ferrocyanide. So that is Pearl's Prussian blue, which gives you blue color. So now let's come to the question. Okay, so identify which is correctly matched. Okay, so look at this here. So we know von Giesen. So starts from below one. Okay, easiest one. Pearl stain, iron is red. That is wrong. You know, iron is blue. Giemsa will give purple color to the mast cells. That's absolutely correct. Alizarin red will give red color to the calcium, not black. Von Cosa will give black color. Von Giesen elastic is for elastic fibers and it will give it black color. Okay, not the yellow color. Yellow color is background color. Okay, so that is what you have to remember. So the answer is 3 only. The answer is 3 only, which we just studied. Giemsa will give purple color to the mast cells. Okay, so that's about stains, which everybody should be clear. Please go forward and revise stains before every INICET exam. It's one of the very, very important questions, right? Okay, let's come to the next question. So this is translocation 1114 causes overexpression of. Now this was a tricky question here. Okay, so it causes overexpression of. So remember, translocation 1114 is a typical translocation of mantle cell lymphoma, and on chromosome number 11 we have cyclin D1, and on chromosome number 14 we had immunoglobulin heavy chain. So this, whenever somebody goes close to the bad boy of hematology, that is immunoglobulin heavy chain, that gene gets activated. So whenever cyclin D gets close to IgH, what happens is cyclin D gets overactivated. So it causes overexpression of cyclin D. It causes overexpression of cyclin D. So okay, so it causes overexpression of cyclin D. That is what you have to be very clear. Now there was another question which was also there in the exam, that is SOX11. So SOX11 is a marker for mantle cell lymphoma. Yes, it is a marker for mantle cell lymphoma, but this translocation does not cause overexpression of SOX11. So mantle cell lymphoma shows presence of SOX11 and cyclin D1. So just think about what was the question. If they're just saying that if this is the translocation, it will show overexpression of which molecule, then it has to be cyclin D. If somebody says which are the immunohistochemical markers or the markers for identification of mantle cell lymphoma, then your answer should be cyclin D1 and SOX11, both of them. Okay, so both of these are the IHC marker, but this translocation only overexpresses cyclin D1. So that's one point that you have to be very, very clear. Okay, so basically, when they talk about only overexpression, so it's an overexpression of cyclin D1. Okay, that point you have to be very clear. If they say which are the markers that can be used for the diagnosis of mantle cell lymphoma, then your answer should be cyclin D1, SOX11, both can be used. Okay, what about CD10? CD10 is a marker for follicular lymphoma, and it can also be positive in Kala positive ALL. Okay, that is common ALL antigen ALL. CD200 is marker for CLL. Okay, so it is marker of CLL. It is positive for CLL. So that is one thing that you have to be super duper clear with, right? So just one more point before we go to the next question. So SOX11 is positive in nearly 90% of the cases of mantle cell lymphoma. So remember, somebody says which marker is positive in 1114 negative mantle cell lymphoma, then also it will be SOX11. Why? Because remember, SOX11 is a transcription factor which is activated in mantle cell lymphoma. So remember, this translocation has nothing to do with it. Okay, so remember, so here we go. So if we have translocation 1114, this leads to overexpression of cyclin D1. So this is what we say in mantle cell lymphoma. We have translocation 1114, which causes overexpression of cyclin D1, number one. Okay, so now that is number one. Number two, in mantle cell lymphoma, there is a transcription factor that is overactivated, which causes overexpression of SOX11. Okay, so SOX11 is positive in 90% of mantle cell lymphoma, which are translocation 1114 negative or translocation 1114 positive. It does not matter. If it is mantle cell lymphoma due to any cause, it will have SOX11. Okay, so there are subset of mantle cell lymphoma which can be 1114 negative. They can also be identified by SOX11. So that's a key point that you have to be very, very clear. So remember, translocation 1114 causes overexpression of which gene? It is cyclin D1. If it is translocation 1114 negative, then which marker can be expressed? Then also which marker can be expressed? Then your answer will be SOX11. So that point should be super duper clear with. Okay, CD200 is basically a marker which is very useful marker to differentiate CLL and mantle cell lymphoma. Why? Because I hope everybody remembers, mantle cell lymphomas are typically positive for CD5, whereas CLLs are typically positive for 5 and 23. Okay, so that is one thing which we have to know. But sometimes we have doubt whether it is a mantle, whether it is a CLL, then we use CD200. So mantle cell lymphomas are always CD200 negative, CLLs are always CD200 positive. So that is one thing which you have to be very, very clear. Okay. So to CD200, I told you, is a marker for CLL. Apart from that, it can also be positive in other leukemias like hairy cell leukemia, but it is always, always, always negative in mantle cell lymphoma. So its negativity is more important. Its negativity is seen in mantle cell lymphoma. That is one point which everybody should be super duper clear with. Okay, understood. So that is this question. So it was a tricky question, but yes, I hope you understand it. Okay. So this was my Jinx question. I hope you remember. So all those who basically saw the Jinx video before going for the exam. So this was asked in the exam. Nobel Prize 2025 was given for peripheral immune tolerance, and this is typically seen in regulatory T cell. And this is the slide that I posted as a Jinx question that it might come in exam. So we had three people. Okay, so these are three scientists who got award in 2025 for peripheral immune tolerance, and they identified regulatory T cells. And what are the markers for the regulatory T cells? So they are CD4 positive, CD25 positive, and FOXP3 positive. And I told you, if there is absence of FOXP3 in some person, this causes a disease called as IPEX. What is IPEX? Immune dysregulation, polyendocrinopathy, enteropathy, and X-linked disease. So it's an acronym. Okay, so that is due to deficiency of FOXP3. So that is typical Jinx that I posted one day before the exam. So you have to know, not only you have to know the Nobel Prize, what did they discover? Number one, what are T regulatory cells, what are the markers, and what happens if they're deficient, what is the disease. Disease is called IPEX. Remember that point always. Okay, right, let's go to the next question. So this was multiple correct options on retinoblastoma. So I got a lot of recall, so I added all the options. Whatever was asked, just check it, you should know all of them. Okay, so what is it? So this was multiple correct options on retinoblastoma. So remember, whenever we talk about retinoblastoma, so if they are germline retinoblastomas, they are usually bilateral. So they are not unilateral, they are usually bilateral. So that's one point that we have to be very clear. Apart from that, they are typically due to loss of function or methylation of RB gene, not STK11 gene. So that also wrong. Now, RB gene is a tumor suppressor gene, and its major function is to control the cell cycle. How does it do so? So normally RB gene, whenever it has no phosphorus, I hope you remember the story of the grandmother. RB gene is the great grandmother of the gene. So when she's a great grandmother, she cannot sit alone. She needs a company. So who is the company? E2F. So normally when she is alone, she will catch somebody. Who is that somebody? E2F, and the cell cycle is off. So this is how the RB gene works. The RB gene is active. So for RB gene to be active, there should be no phosphorus that should be attached to it. So RB gene should be alone. Then only she'll catch E2F, and the cell cycle will become off. If you attach phosphorus to the RB gene, so this phosphorus is given with the help of cyclin and cyclin dependent kinases. So cyclin dependent kinases give phosphorus to RB gene. So now the grandmother is saying, okay, I have got a new company of phosphorus. So let me leave E2F. Then she will leave E2F, and the cell cycle will move from G1 to S phase. That is what will happen. So can I say, whenever the RB gene is phosphorylated, when the RB gene is phosphorylated, then the RB gene is off because the cell cycle is running, cell cycle is moving, cell cycle is moving. So cell cycle becomes on when the RB gene is phosphorylated. That means the RB gene becomes inactive. So if you have to make the grandmother active, you have to remove phosphorus. Then the grandmother will go and catch E2F. So can I say RB gene is active when she's alone? RB gene is active when she's alone. So how do you want to make her grandmother alone? Remove the phosphorus. So can I say it is not inactive, it is active in hypophosphorylated state. Okay, so if you remove phosphorus, then the grandmother will become active. So this is also a wrong option. This is also a wrong option. Now, coming to the next, this is called guardian of the genome. No, guardian of the genome is the molecular policeman, P53. So this is not the guardian of the genome. Obviously, what is the mechanism of action of RB gene? Mechanism of action is always, it's a tumor suppressor gene, so it has to be either loss of heterozygosity, loss of function, or methylation. So yes, oncogenesis will occur whenever there is loss of function. Increased risk of osteosarcoma, yes. So whenever a person has deletion of RB gene, it causes risk of retinoblastoma. The second cancer that can occur in retinoblastoma patients is osteosarcoma. So that is also correct. So this was the multiple correct option type. So that is why option 5 and option 6, if they were there, it is correct. Okay. So remember, whatever was the options, remember this should be very clear in your mind that it's a tumor suppressor gene. So its loss of function makes it cancerogenic or oncogenic, and its mutation causes retinoblastoma and osteosarcoma. And RB gene is always active. It works as a tumor suppressor gene only when you remove the phosphorus. If you add phosphorus to the RB gene, then the E2F, the cell cycle will start running, and then the RB gene is inactive. Okay, and the gene mutated is RB obviously, and whenever we have germline RB mutation, it is usually bilateral. Okay, bilateral. So that point should be super clear with everyone, right? Okay, so coming to the next question. So this was a simple acute angle branching fungus that was given. So you can see here it is branching acute angles, and there is septa. So whenever you see A, okay, what is A? Acute angle branching and septa. This is aspergillus. This is aspergillus. Okay, so that should be very clear. They can ask you which stain is this. This is silver methamine stain. Okay, so this is silver methamine stain. Okay, so that point should be very clear. Okay, they can ask you that again. Okay, so that is about your aspergillus. Let's go to the next question. So a female with vulvar skin lesion which were white plaque like was given, and the patient has intense pruritus. That was also given. That was told to me by a student. And on examination, epidermis is thinned out and there is loss of red ridges. What is the diagnosis? So of course the diagnosis is lichen sclerosis, but they didn't give you confusing options here. The options were very clear cut. Okay, but they can confuse it in future. So remember, whenever we talk about pruritic lesions of the vulva, okay, whenever we talk about pruritic lesions of the vulva, so there are two lesions which are basically which can cause leukoplakia, but you should know them. Okay, so what are these two lesions? One is lichen simplex chronicus and the other is lichen sclerosis. Both of them are intensely itchy lesions. Both of them are intensely itchy lesions. Remember, what is the classical finding? So whenever they give you the epidermis is the surface of the vulva has a plaque like finding, and the epithelium is very thin, cigarette paper like, okay, thinned epithelium. So that should be lichen sclerosis. Okay, so this is very classical. Why? Because this has to be picked up because it's pre-neoplastic. So it has increased risk of squamous cell carcinoma, especially HPV independent squamous cell carcinoma. So whenever a female is getting vulval cancer, which is not related to HPV, think of precursor lesions like lichen sclerosis. Remember, it has homogenized collagen, which is classical feature. What about lichen simplex chronicus? So there is lot of itching to the patient. Itching causes lot of thickening of the epithelium. So here, the epithelium, the overlying skin is very thickened and leathery. That's a catch point. So overlying thing, the skin is thick, leathery. Then think of lichen sclerosis, lichen simplex chronicus. So remember, name itself says chronicus. It has become chronic because there is a cycle of itching, healing, itching, healing, itching, healing. So there is acanthosis. The epithelium gets thickened up. Okay, so that's very typical here. The epithelium is thickened, and of course, there's no homogenization of collagen, and it has no malignancy risk. Okay, so it's just a chronic lesion because of itching, healing, itching, healing, itching, healing. So it has overall thickened epithelium. So these two conditions are very pruritic lesions. They can be asked in any condition. So to be very clear to differentiate these two. So we have lichen sclerosis and lichen simplex chronicus. Okay. So now let's look at the images of both of them. Okay, so if you look at the images, so they are non-neoplastic causes of leukopenia. Both of them causes intense pruritus. Look at this. So epithelium is thinned out. Okay, so there is even loss. Normally the rete should be like this. There is no rete. So there is loss of rete, thinned out epithelium, and you can see on the top upper part of the epithelium there is homogenized collagen. So I'm going to enlarge it for you. for you to see. So what do you see here? So you can see the epithelium is very, very thinned out. There is loss of retinages, and on the top there is homogenization of the collagen. Okay, all the skin appendages are also lost because it has become very homogenized collagen. And just below that you can see a lot of lymphocytes. So there are band of lymphocytes there. So three things here: thinned out epithelium, homogenized collagen, and band of collagen. So whenever you see these three things, okay, so again, epithelial hypertrophy, overlying keratin can become thickened because of itching, but homogenization of collagen and band like lymphocytic infiltrate. When you see these three things, close your eyes, mark lichen sclerosis. Okay, typically remember these patients typically present with polyclane white or ivory white patches. That's a classical picture that they are given for lichen sclerosis. The vulva shows you typical white lesions. Okay, so that has to be clear. In contrast to this, look at this. So this is your keratin layer. So there is hyperkeratosis. Look at the epithelium. This is also so thickened. So this thickening of the epithelium is called as acanthosis. So there is acanthosis here, and you can see here this is hyperkeratosis. Hyperkeratosis. So you see hyperkeratosis, and this overall skin is also very, very thickened here. So this is acanthosis, and this is what is called as lichen simplex chronicus. So this is by repeated cycles of itching and healing. That is what it occurs, and it is not at all neoplastic, but it is itchy. So you should be very clear with this. Okay. So let's come to the question here. A typical female with, white plaque-like lesions or cigarette paper skin or a polyclane or ivory-like skin surface, thinned out epidermis, lost lateral bridges, lichen sclerosis. Lichen planus also has band-like lymphocytic infiltrate, but there is no homogenization of collagen, no loss of retinages. So they also have band-like lymphocytic infiltrate. And here they will give you very typical bodies. These are called as civate bodies. So they will give you civate bodies. So that is the classical bodies that they will give you. Okay, rest is simple. Candida will show you spores, VIN will show you dysplasia. Okay, so that has to be very clear, right? So everybody should be super clear with this. Let's look at this. For lipid fixation, which stain should you use and how should you do? I've always told you this point that lipid is one thing which washes off when you fix it in formalin. So you always have to stain it fresh. So fresh means frozen section. So whenever you have to seed lipid, you have to seed fresh in the frozen section. And in this, you have to use a stain called as oil red O. If you put it in formalin, it will wash off. In such cases, you can see it, but you have to use a Sudan black stain. So then you will have to use Sudan black stain. Okay, and that is the disadvantage here. Immunohistochemistry has no role here. So that is typical for lipid fixation that we have studied so many times. Okay, which of the following is correct regarding Peutz-Jeghers syndrome? A repeat question. Everybody knows this. So remember, what is the classical feature of Peutz-Jeghers syndrome? I've always told you like this. So this is a Peutz-Jeghers syndrome. Typically occurs in the age group of 11 to 22 years, and that is what you have to remember. So it typically shows you pigmentation of the mucosa. This pigmentation can be of oral mucosa, anal mucosa, any mucosa. It typically occurs in jejunum. So they typically presents with intussusception. Okay, so they typically present with intussusception. And the gene that is mutated is tumor suppressor gene, which controls energy, that is STK11. So STK11 is a typical mutation which you see here. So PJS. Apart from that, I told you they typically this Peutz-Jeghers syndrome is a hematomatous polyp. That is, there is hematomatous polyp because there is a haphazard arrangement of muscle here. So look at this, there is an epithelium here, there's a muscle here, and suddenly the muscle goes inside the polyp and it starts branching. That should not happen. So when you see muscle which starts arborizing inside the polyp, so that is very typical of Peutz-Jeghers syndrome. So arborizing muscle is one point that you have to be very, very clear. Also, Peutz-Jeghers syndrome itself does not give rise to colon cancer directly, but it increases the risk of other cancers. So which other cancers? So I told you this, always remember Peutz-Jeghers syndrome. P for pancreatic cancers. J is JB, breast cancers. And S, it causes sex cord tumors, sex cord Sertoli tumors. of ovary or testis. Okay, so that's very, very classical other tumors which can occur in this. So if you know this, you will know everything about Peutz-Jeghers. Now let's try to answer. And all the polyps of the intestine are inherited in an autosomal dominant manner, except there is only one polyps here, which is called as Mutti related polyposis, which is autosomal recessive. Okay, so this is autosomal recessive. Okay, that is what you have to remember. All the others are autosomal dominant. Let's go to the question here. Which of the following is correct regarding Peutz-Jeghers syndrome? It shows you arborizing pattern of the muscle. Absolutely correct. True. Loss of heterozygosity of STK11. It's a tumor suppressor gene. It has to have loss of heterozygosity or methylation. Perfect. Okay. So it can have multiple GI polyps. Yes, it can have multiple jejunal polyps and they can undergo intussusception. It is autosomal recessive. Absolutely not. It is autosomal dominant. Congenital hypertrophy of retinal pigment epithelium. That's a classical feature of familial adenomatous polyposis. That's familial adenomatous polyposis which shows you this, not Peutz-Jeghers. Okay. So congenital hypertrophy of retinal pigment epithelium is with FAB. Okay. So Peutz-Jeghers shows you pigmentation of the oral mucosa, anal mucosa. Okay. So the answer is A, B, C. That is what you have to be clear. Okay, so now next is which of the following is not a major or minor criteria of diagnosis of rheumatic fever. So this again I told you that this is an update which came in the diagnostic criteria of rheumatic fever, and that is what we had to be very, very clear. But this was a stat question because short PR interval is never a feature. It is always prolonged PR interval. Okay, so that is never a criteria. But what is the change? You should know this. Okay, so this was an easy question, but change should be prepared for the next time in the exam. So remember, whenever we talk about the diagnostic criteria of rheumatic fever, so this is a modified Jones criteria. So remember, the rule says simple. So either you should have two major or one major and two minor, along with the antecedent history of group A beta hemolytic infection. Now, first, when we talk about major infection, we have two populations, low risk and high risk. Okay. So, we'll talk about what is low risk and high risk. But first, what is the criteria? So, criteria is very simple. I have always told you the code, that is CPSC. Okay. So, CBSC की जगह बोलना है CPSC. Okay. CPSE. Okay. So, that is it. So, C is the carditis. P is polyarthritis. C is 2C. Okay. Carditis and chorea. P. Polyarthritis, S. Sydenham's nodules, and E. Erythema marginatum. So that's CPSC. So polyarthritis, okay, P is polyarthritis, that goes for low risk population. But wherever we have high risk population, like in country like India, where there is a lot of overcrowding, poor hygiene, so we are high risk population. In such cases, the criteria says that even if you get monoarthritis or if you get polyarthralgia also, that should be considered as a major criteria. Rest everything is similar. That's the only change. Okay. So even if you get monoarthritis or polyarthralgia, think it as a major criteria. Why? Because the risk is very high. So even if you get one joint pain, immediately you should get activated. It can be acute rheumatic fever. So that's one point that everybody said. Apart from that, when we talk about the minor criteria, guys, you have to understand again low risk and high risk. So what's the difference? So in low risk, so if you don't have polyarthritis and you just have polyarthralgia, then you take it as a minor criteria. So the rule is very simple here. So first thing should be fever. So but the cutoff of the fever is important here. Okay, what's the cutoff of the fever? More than 38.5. More than 38.5. Second, so fever, ESR more than 60 millimeter per first hour. Okay, so more than 60 millimeter per first hour, or CRP can be increased more than 3 milligram per deciliter. Then prolonged PR intervals and polyarthralgia. So very simply you can remember it as fever, ESR and PR interval. Okay, so that is FEP, fever, ESR and PR interval should be prolonged. Polyarthralgia is also one of the minor criteria. That's it. That's classical low risk. What about India? Countries like India, where there is again very high popular risk of having acute rheumatic fever. So they said, okay, fever, but if fever, we have to decrease the cutoff. Even if the fever is more than 38 degrees, you should get activated. So more than 38 degree fever is getting activated. Second, ESR. You will not wait for 60. Even 30 is okay. Okay, so ESR more than 30 get activated. Okay, PR interval prolonged, and last, monoarthralgia. So we have already taken that patient has polyarthralgia in high risk major criteria. Polyarthritis, major criteria. Monoarthritis, major criteria. Now we have, even if you have monoarthralgia in high risk population, you should get activated that it should be taken as a minor criteria. So remember that point always. Okay, so that is about high risk and low risk differences. In high risk, you don't want to miss any case, so you have decreased your thresholds. You have decreased the threshold for fever, you have decreased your threshold for ESR, you have decreased your threshold for arthritis and arthralgia. So these are the 3 points that you have to be very, very clear. Now, once we are clear with this, what is a low risk population? So what do you understand by a low risk population? So remember, a low risk population is that in a population where acute rheumatic fever occurs in less than 2 per 1 lakh school children, or if the patient has got a heart disease, rheumatic heart disease, in less than 1 per 1000 patients, then it is low risk. Okay, so only 1 case per 1000, less than 1 case per 1000 at any age if there is a heart problem, or if you've got rheumatic fever in less than 2 per lakh school going children, then you should think of low risk. All the others are high risk. Okay, so that is the criteria which you should be clear, and that's a updated criteria which you have to remember. So the question that was asked was very easy, because shortened PR interval to kabhi nahi hota hai. Okay, all the others can be followed. And one more thing, okay, so this was a multiple choice portion. One more point was there. Okay, so it was not erythema nodosum. Okay, so it has to be erythema marginatum. So some of the students told me that, ma'am, it was erythema marginatum. Some of the students told me that it was erythema nodosum. So I'm not sure what was it, but if it was erythema nodosum, it is not the criteria. It should be erythema marginatum. So that is another point that you have to be very clear. Okay, so that is another checkpoint that you have to remember. Okay, so they can change it like that. So remember CPSE. So carditis, polyarthritis, okay, Sydenham's chorea, and erythema marginatum. Okay, so Sydenham's nodules, we have already talked about it. So whenever we are talking about this, so remember Sydenham's chorea and subcutaneous nodules. Again, we have talked about this already. So again, it should be erythema marginatum, not erythema nodosum. Erythema nodosum is a manifestation which can be seen as an extraintestinal manifestations of inflammatory bowel diseases. Okay, so remember that point always. Okay, so that point should be super duper clear to you. Okay, so that is one thing which everybody should be super duper clear with. Okay. So that is again a thing, but just check the question. Some students told me that it was erythema marginatum. Some students told me erythema nodosum. If it was nodosum, it's not there. It's not a criteria. So both of them are not the answer here. Okay, perfect. Now, next question is true about HPV. So whenever I'm talking about true about HPV, so remember HPV, we already, this is again repeat question. We have talked about it. It is a DNA virus. We know that it is an oncogenic virus. Perfect. It is not an RNA virus, and it typically enters into the base of the epithelium. So that's very, very typical. It enters into the base of epithelium. So either through abrasion or any cause, it enters into the base of the epithelium. That's where it infects. So that's very, very typical. They can ask you HPV associated cancers. You always remember it has oral cancers, it has vaginal cancers, it can be vulval cancers, it can be anal cancers, it can be oral cavity cancers, especially posterior part of the tongue. And the gene that is associated is E6 and E7. Remember, E6 typically affects P53 gene and it causes activation of TERT. E7 typically affects RB gene. Okay, typically goes and binds to RB gene and makes it inactive. That's one thing. And apart from that, it can bind to cyclin dependent kinase 1 family, that is P21 family. Okay, so it can go and inactivate P21s also. So that's very, very typical of your HPV virus also, which you should be remember the cells which are infected by HPV are koilocytes. So koilocytes are typical squamous cells which have racinoid nucleus, and they have perinuclear halo. So they are squamous cells with racinoid nucleus and perinuclear halo. So that's very, very typical of koilocytes. Remember that. Okay. Now let's go to the next one. So laboratory evaluation shows a patient has hemoglobin of 9. MCV is 73. So whenever MCV is less than 80, it is a microcytic anemia. So they asked you which of the following conditions should be considered in differential diagnosis. So all of you know that whenever I'm talking about microcytic hypochromic anemia, so microcytic Hypochromic anemia. The code is very simple. Cetal. Okay. Sideroblastic anemia, iron deficiency anemia, thalassemia, anemia of chronic disease, and lead poisoning. So these are the causes of microcytic hypochromic anemia. Now you just know it. Iron deficiency, thalassemia, lead poisoning, vitamin B12 deficiency does not occur. So the answer is A, B, and C. Okay. So that's typical easy microcytic hypochromic anemia. No doubt about it. Okay, onion skin fibrosis is seen in which condition? Now, this is one question again, which is repeat question again and again. They are asking this question. Okay, so there are two conditions which you should be knowing: primary biliary cholangitis and primary sclerosing cholangitis. So, answer is primary sclerosing cholangitis, and I have explained to you. This is just a snapshot from the workbook also and from the videos also. So, we have, when we talk about cholangiopathy, we have two types of cholangiopathy: some disease which can occur inside the liver or outside the liver. So whenever there is something which is affecting outside the liver, larger extrahepatic bile ducts are affected, and in this you see onion skinning. So what do you see? You see the bile duct in the center, and onion skinning around it. So that is very typical of primary sclerosing cholangitis, and it is typically caused by pianca. Whereas when the small and medium bile ducts are involved, this is an autoimmune process. Usually, these patients have anti-mitochondrial antibodies, and there are lymphoid infiltrates which are seen around the bile duct. So, there's a bile duct, around that, a lot of lymphoid infiltrate is seen. So that is what you have to be very, very clear. A lot of lymphoid cells around the bile duct, that's primary biliary cholangitis. A lot of fibrosis in an onion skin manner around the bile duct, that is primary sclerosing cholangitis. So name itself says sclerosing cholangitis. So there's a bile duct in the center and there's sclerosis around it. Remember the antibodies? Last time the question was anti-mitochondrial antibodies are positive in which disease? It's primary biliary cholangitis. Pianca, they can ask you in future, is positive in which disease? Primary sclerosing cholangitis. Apart from that, it is also positive. Pianca can be positive in multiple conditions. It can be positive in ulcerative colitis. It can be positive in microscopic polyangiitis. Okay, so all that have to be known. So this is typical cholangiopathies which you should be super duper clear with. Right. Now, what is the most common site of melanoma in Indians? So, in Indians, we typically have acral type, which is more common in the hand and feet, whereas in world, superficial spreading is more common, which is common in trunk. Now look at this. So this was another question that was given. A patient has a corneal ulcer, and he has a history of contact lens use. Which stain should be used? See, whenever a person has a history of contact lens use, he can have fungal keratitis, acanthamoebas. Okay, so it can be any organisms like fungus or acanthamoeba. To identify them rapidly at the bedside, we use a stain called calcofluor white. So what does calcofluor white do? It quickly binds to the chitin or cellulose which is present in the fungal wall, and as soon as you put UV light on it, it starts shining. So it's very rapid stain to pick up that a person is having a fungal or an acanthamoeba keratitis. Okay, so this is how it looks like. So it can identify any fungus because it has a tendency to bind to chitin, and this is calcofluor white, and as soon as you put UV light, it starts shining. Okay, so this is a broad bunch based branching here. So this is just an image from blastomyces. So point to be noted is it can identify any fungus. Okay, so because it will, if any fungus, whatever fungus has chitin or cellulose, it will go and bind to it and it starts giving fluorescence. Okay, so when you see a broad based bud here, like in this case it is blastomyces. So that is calcofluor white, which is a rapid stain. What about other options? So gram stain is for bacteria, no utility here. GMS, gomori methamine silver stain, is, it takes time, it's not a rapid stain. Acid fast is for mycobacteria, has no utility here. Okay, let's come to the next question. So, what is the features of the neuroendocrine tumor? So, whenever we talk about neuroendocrine tumor, these neuroendocrine tumors have subtle features which you should remember. So, what are the subtle features? This is again a snapshot from the video and the workbook itself. So, neuroendocrine tumors typically have, what's a classical feature? So, they typically have a very classical microscopy, that they all have they all have stippled chromatin or salt and pepper chromatin. So that chromatin is very typical for all neuroendocrine tumor. Second, if you look at them under electron microscopy, they will typically show you these kind of granules. These are called dense core granules. Again, if you use the IHC, they all will be positive for same IHC, like that is synaptophysin, chromogranin, CD56, INSM1. So I hope INSM, everybody remember, this was a question that came last year in an INICET exam. It's a nuclear neuroendocrine marker. Okay, so that's very typical. So you can't differentiate them just on the basis of light microscopy or electron microscopy. So they have certain subtle other features also which helps in identifying which all tumors are neuroendocrine tumors: pheochromocytoma, neuroblastoma, paraganglioma, carcinoids, small cell carcinoma of the lung, medullary carcinoma of thyroid, and Merkel cell carcinoma of the skin are all neuroendocrine tumors. So now once you've understood this, look at this. So what are the features of neuroendocrine tumor? Light microscopy shows secretory granule. Wrong. It is electron microscopy that shows you dense core granule or secretory granule, not light microscopy. So subtle point, but very important. Cannot be distinguished on light microscopy. Obviously, all of them show you stippled chromatin or salt and pepper chromatin, so you cannot differentiate them. Organ specificity cannot be asserted. You cannot, because all of them are having similar features. Correct. Stippled chromatin is characteristic. Correct. So stippled chromatin is hallmark. So the answer is 2, 3, and 4. So it should be 2, 3, and 4. So it should be 2, 3, and 4. So that should be the correct answer here, 2, 3, and 4. And that is very, very classical here. Okay. Now let's go to the next question. So Menzer index that was given was 11 and with normal RW. We have always told you whenever the Menzer index, what is Menzer index? MCV by RBC. So whenever we have any hemolytic anemia, the RBC count is high. But it is a microcytic anemia, so MCV will always be low. So therefore your Menzer index will always be less than 30. So whenever they tell you that a person is having Menzer index less than 30 and the RDW is normal, you should always think of thalassemia. So whenever it is a thalassemia trait, okay, so whenever it is a thalassemia trait, which thalassemia? Thalassemia trait. So whenever it is a thalassemia trait, how will you diagnose them? By hemoglobin HPLC. So that's the way of diagnosis. So diagnosis should be hemoglobin HPLC. If HPLC is not given in the option, then electrophoresis. Okay, hemoglobin electrophoresis should be done. Serum ferritin, TIBC, serum iron is done for iron deficiency anemia, and in iron deficiency anemia, because it's an iron deficiency anemia, so your hemoglobin is also low, your RBC is also low, your MCV is also low. So your Menzer will always be more than 13. Bone marrow aspirate has no utility usually in hemolytic anemia. So we don't do bone marrow examination in hemolytic anemia commonly. Okay. Right. So that's the answer to this case. The answer is hemoglobin HPLC or electrophoresis. Okay. So what is a test we do for allelic exclusion on antibody? So this, what is allelic exclusion? You have to understand this point always. So we have two alleles. We get one from the mother, one from the father. Okay. So now what happens is we get a different set of B cells also in this. So whenever we get a different set of B cells, normally what will our body do? So it will select only one allele. Okay, either a paternal allele is selected or a maternal allele is selected, and once it's selected, it will undergo VDJ recombination. So either a heavy chain recombination or light chain recombination. So it will undergo VDJ recombination in the heavy chain. So this VDJ recombination, if you start studying that, okay, this VDJ recombination will resemble only one of the parents. Okay, so VDJ recombination of a child should resemble one of the parent, either the father or the mother. So this means that this test will help you identify that from which allele we are making the antibodies, okay, from paternal or maternal. So that is the one of the specific tests which we do for allelic studies, allelic exclusion studies. So you have to do VDJ studies. Why not whole genome? Whole genome means, see, we have B cells of both the parents, alleles of both the parents. Okay, so if you do whole genome, both the alleles will be identified, paternal also, maternal also. How do you know which is active? So you can't identify that because whole gene sequencing will only show you that both the sequences are there. So they're there. You can't identify which is working. Okay, so that is why this is of no utility. Why not ELISA? See, ELISA will work after this. Now this recombination will form antibodies which you will identify by ELISA. So how will you know whether this antibody is from father or mother? You can't identify that. There is some antibody which is coming. So it is IgD, IgM, IgA. You don't know from which parent it is coming. You can't identify this with IG, ELISA. Northern blot. Northern blot is for RNA. Okay, again, you just able, so there is a recombination and there's some RNA which is there. You can't identify that this is which whose RNA it is. You can't. So for that, you have to see VDJ recombination. Only when you study that and that resembles one of the parent, you can say that this is coming from which allele. So the answer to this question is allelic selected VDJ study. Okay, so you have to identify this. That's very, very important. Now let's look at this question. So molecular study shows there is a RAS mutation with loss of GTPase activity. So that means RAS has become overactivated. Now there is nobody who can control it. So I hope you remember that the RAS belongs to GTP pathway. So whenever GTP is activated, it binds to RAS and then the RAS is going to activate further. So this mutation, RAS mutation, is very typical in pancreatic or biliary areas. So very, very typical in pancreatic cancer, cholangiocarcinoma, colon carcinomas. This area, this belt is very commonly associated with RAS. So you see pancreatic cancers will typically have RAS mutation. What is the most common mutation of papillary thyroid cancer? BRAF. What is the most common mutation of retinoblastoma? RP gene. CML is due to translocation 922, that is ABLBCR. So the answer here will be pancreatic cancer, which you should be very clear. Coming to the last one. So this was another question which everybody gave me. So look at this. Which of the following best describes RAS activity? So for that, look at this diagram, which I have already taught you so many times. So I just told you that RAS belongs to the family of GTP family. So whenever the GTP is active, it activates RAS. When RAS is active, it activates BRAF. BRAF will go and activate MAP kinase pathway, which will start causing proliferation. Apart from that, it also activates PI3 kinase pathway that will help in protein synthesis and form mTOR. Okay, PI3 kinase is controlled by P10. So this is a diagram which I've taught you so many times in neoplasia, isn't it? So once you've understood this, look at this, the first question. So which of the following best describes RAS gene? Constitutive activation of GTP binding leads to increased MAP kinase activity. Correct or not? So absolutely correct. Whenever there is an activation, whenever GTP is activated, it leads to activation of RAS, which activates MAP kinase activity, which I just showed you. So that's absolutely correct answer. Enhanced DNA repair, it's not DNA repair gene. So RAS is a proto-oncogene. DNA repair genes are a different set of genes. So this is not no role in DNA repair. Inactivation causes loss of control, cell cycle control. It's not a cell cycle controller. It has no role in cell cycle controlling. Cell cycle controller is RB gene. Okay, not this. Okay, it increases tyrosine kinase activity. No, that's a function of ABL. So ABL usually translocates to BCR and increases tyrosine kinase activity. Again, this is not the activation, this is not the function of RAS gene. So the answer to this is A, that is whenever GTP activates, it activates MAP kinase pathway. So that's very typical of RAS gene, which you need to be clear. Okay, so true about rheumatic heart disease. Okay, so this was again a easy question, a googly question. So first, it is caused by group A beta hemolytic streptococcus. That's true. As shock bodies are seen, that's true. It shows only myocarditis. No, it's pancarditis. I've already told you it shows you endocarditis, myocarditis, and pericarditis. Remember bread and butter pericarditis? Yes. So it's not there. Most common valve, mitral valve, not aortic valve. So the answer to this is A and B, and I hope you remember this. These are typical Aschoff nodule, nothing but collection of your macrophages. Activated macrophages here are called as NHCO cells, right? And they can fuse to form giant cells, and this is very characteristic hallmark of rheumatic heart disease. Okay, so that was about rheumatic heart disease. Coming to the next question, what happens when there is a deacetylation of chromatin? So this is a question on epigenetics, and I've already told you this and taught you so many times. So what is the classical point here? So whenever we talk about chromatin, so remember the rule. So chromatin is histones and DNA. So histones and DNA, and whenever we talk about this, whenever methyl group is attached to histones or DNA, it causes condensation of chromatin, and that chromatin becomes inactive. That chromatin becomes inactive and it stops working. Whereas what happens oppositely? If you attach acetyl group, if you attach acetyl group, okay, so if I'm saying I'm attaching methyl group, it causes condensation. If I'm adding acetyl group, it will cause A for activation. It will open up the chromatin and it will become active. Okay, so that's a rule. So methylation usually occurs in CPG islands. Wherever there is C and G together, that is the area where methylation usually occurs. Okay, so remember, suppose somebody is saying you remove the acetyl group. So acetyl group activates. So if you remove the acetyl group, that part of the DNA condenses. So it causes condensation of the chromatin. Why is it important? Because epigenetic modifications. So study of these inherited chemical modification is called epigenetics. However, these biochemical groups can be attached or removed, so it can be reversed. That is why knowing this is very important, because if you have any bad gene, okay, and you want to inactivate it, so you attach methyl group to it and it will become inactivated. So we have a lot of drugs in the market which do the same. Okay, so we have DNA methyl transferases. So DNA methyl transferases will attach methyl group to the defective gene and it will get inactivated. So we have drugs like this. Okay, so azacitidine is a very common drug which is used for MDS and acute myeloid leukemia, which does this. Okay, so these point to be noted here is this is an epigenetic modification. Usually we study them. We are born with these biochemical modifications. Okay, and when you study what biochemical modifications are present, this is epigenetics. So that is why the two identical twins are not similar to each other. Why? Because they have different biochemical alterations. So when you study these biochemical alterations, this is epigenetics. But when you change them, can you change them? Yes, you can reverse them. So these are reversible. That's the point that you have to remember. And we have drugs coming up who can do this. Okay, so that is why this question was typically asked. Okay. So this was gotchas, which is always a question. Either they will give you crumpled tissue paper appearance, or they'll ask you what is a gene which is defective. So remember that it is caused by the defective beta glucocerebrosidase gene is defective. It's deficiency, and it shows you crumpled tissue paper appearance. So that is very very typical of gotchas. Foam cells and sphingomyelinase defect. Okay, so this is very characteristic of Niemann-Pick disease. So Niemann-Pick disease will show you foam cells and your sphingomyelinase defect. This is Niemann-Pick. Okay, so that is one question which comes every time in exam. So be very sure to know these crumpled tissue paper cells and these foam cells. Okay. Okay, next was a question which was little tricky again. So patient presents with the no hematuria, serum creatinine for 2. Which of the following is used to diagnose nephrotic syndrome? So if you look at the diagnostic criteria of nephrotic syndrome, it relies on 3 features. That's the snapshot from Harrison, which says you should have edema, hypoalbuminemia, that is less than 3.5 gram per deciliter, or proteinuria, more than 3.5 gram of protein loss per day. So this is the diagnostic criteria. Now, this syndrome is often associated with hyperlipidemia. So, which of the following is used to diagnose or helps in diagnosis? Then we have proteinuria, hypoalbuminemia, both are there. Hyperlipidemia is not a diagnostic criteria but helps in diagnosis. Okay. In fact, this is another point that has typically added here, that if you see uh, urine in nephrotic syndrome patients, you will see that they will have these fat laden proximal convoluted tubule cells, and they will typically show you Maltese cross appearance on the polarizing light. So this is so diagnostic. So if you do the urine examination in nephrotic syndrome, you will see this Maltese cross because these are oval fat bodies. So these proximal convoluted tubule cells loaded with fat are called as oval fat bodies. So it's so suggestive in the diagnosis. So although hyperlipidemia is not a diagnostic criteria, but it helps in making the diagnosis. So that's a point that everybody should be knowing it. So if it was which helps in making the diagnosis, then your answer should be A, B, and C. Which is a diagnostic criteria, then it should be only edema, hypoalbuminemia, and proteinuria. So these are the subtle things that will help you in making the diagnosis. And this time, INICET exam was trickier in that sense. So now, which of the following is correct regarding steps of PCR? So we always remember DAE. We have denaturation, annealing, and extension. Hybridization is not a feature of PCR. Hybridization is a feature of fish. So we don't do hybridization in PCR. Okay. So remember, we always do denaturation first, which is done at 94, and then we anneal. and when we anneal, we do it at 54 degrees centigrade, okay, and then we extend with the help of Taq polymerase, which is at 72 degrees centigrade. So this is just a way in which multiple copies from a DNA is done, and after that we stop this process by various methods. Either it can be a chain termination method, which is called Sanger sequencing, or we can just see single base primer extension. Okay, so that, like, when we know the gene mutation, exact point mutation, then we do single base primer. Or nowadays we can do RT-PCR. We take the RNA, change it into DNA, and then study it. Or we can do gap PCR for deletions. Or nowadays the most important one which is coming is whenever we have a contaminated sample. Earlier days we used to do pyro sequencing. Nowadays we do NGS, next generation sequencing. Again, this is from the videos only. We have studied these techniques in detail earlier also. MLPA is nothing but multiplex ligation probe analysis for both deletion and duplication together. So the point here was very simple. So there are two questions which has been asked till now. One, what are the steps of PCR, which was very simple, DAE. Some people confused with hybridization. Hybridization is a property of fish, bacha log. No, don't do that wrong. Okay. The second thing which students said has been asked was Sanger sequencing. Sanger sequencing is based on chain termination method, and we use DDPCR, DD NTPs here. Okay, so that was also asked as a question once. Okay, so that is dideoxy NTPs are used in which type of PCR? That is, after extension, you have to stop the chain. How to stop the chain? With the help of DDNTP, and that is gold standard. Sanger is one of the gold standard, quickly being replaced by NGS, next generation sequencing. Maybe in the coming 2 to 3 years, NGS will be the new gold standard. Okay, because PCR is a very time taking step. It takes a lot of time. NGS is very faster and gives you very accurate result. They have adapters in them, so that's very, very good technique. Okay, so that was about PCR. We have to remember that. Okay, so that was the last question, guys, and with that we finish your INICT November 2025 recall. I hope you understood something and you'll not do these things wrong in the exam next time, right, guys?